Hello, my name is Santosh Abraham. I'm working as a specialist registrar in endocrinology and diabetes at Scarborough General Hospital. So today we are to discuss about osteoporosis, the NICE guidelines. So let's start with the NICE clinical knowledge summaries. So osteoporosis for prevention of fragility fractures. The summary is as follows. So osteoporosis in general is characterized by low bone mass and structural deterioration of bone tissue. So it's both the low bone mass and the structural deterioration. So it increases a risk in bone. It increases the bone fragility, and hence the risk for fracture. On itself, osteoporosis is asymptomatic, and it is often undiagnosed until you have a fragility fracture. In England and Wales, it is estimated that annually around 180,000 fractures occur as a result of osteoporosis. So it is characterized by low bone mass and structural deterioration that increases bone fragility, which increases the risk for fracture. Asymptomatic, but detected when a fragility fracture occurs. So basically the osteoporotic fracture is a fragility fracture, and it occurs as a result of increased bone fragility. So usually in the wrist, spine and hip. So what's a fragility fracture? A fragility fracture is defined as a fracture following a fall from standing height or less. Although vertebral fractures may occur spontaneously or as a result of routine activities. So it could be from a fall from standing height or less, and the vertebral fractures could occur spontaneously, or the fractures could also result from as a result of routine activities. So what are the risk factors? Female gender, increasing age, menopause, corticosteroids, smoking, alcohol, previous fragility fracture, rheumatoid conditions, rheumatoid arthritis, inflammatory arthropathies, history of hip fracture in the parents, BMI of less than 18.5. So females, age, menopause, corticosteroids, smoking and alcohol, previous history of fragility fracture, family history of hip fracture, RA and inflammatory arthropathies, and a decreased body mass index below 18.5. So the 10-year fragility fracture risk score, which is very important before doing a DEXA or before starting a bisphosphonate. So it's very important to do the 10-year fragility fracture score. There are some exceptions. So you could directly proceed to the DEXA and bisphosphonate if the patient is above 50 years with a history of fragility fracture. Directly you could go for the DEXA. Or under 40 years of age who have a major risk factor for fragility. Then a DEXA could be directly done with appropriate referral to the specialist. And with vertebral or hip fractures, it could be it could start with treatment even without doing the DEXA. So above 50 years of age with a history of fragility fracture, or under 40 years of age with a major risk factor for fragility fracture, or with vertebral or hip fractures, the 10-year fragility risk score should not be calculated. I mean, it's not a must that it should be calculated. So these are the exceptions. So once again, above 50 years of age with a history of fragility fractures, under 40 years of age with a major risk factor for fragility fracture and with vertebral or hip fractures. So how is a 10-year fragility risk fracture risk calculated? It's calculated using the Q fracture. It's the preferred method, or the FRAX online assessment calculators. So either with the Q fracture or with the FRAX online. So you have, once the 10-year fragility risk fracture risk is calculated, you divide it into 3 categories: high risk, intermediate risk, and low risk. For both high risk and intermediate risk, you offer a DEXA scan to confirm osteoporosis. But for low risk, it is not offered, or even the treatment is not offered, but just given the lifestyle advice. Here the intermediate risks are where in people whose fracture risk is close to the recommended threshold, and also who have risk factors which may be underestimated by the FRAX, such as people on corticosteroids. So for high risk and intermediate risk, you offer a DEXA scan, but for low risk, you give the lifestyle advice. So a bisphosphonate should be offered to people with a BMD, bone mineral density T-score of 2.5 or less, if appropriate, and if there are no contraindications. If there is a premature menopause, HRT could be offered to reduce the risk of osteoporotic fractures and for the relief of menopausal symptoms. But in all other cases, HRT is not at all indicated because of the increased risk of having complications. Risk factors should be addressed, such as smoking, alcohol, calcium and vitamin D deficiency. Risk factors for falls should be managed if present, so falls assessment should be done. Follow-up should be arranged to assess and manage the adverse effects of bone-sparing treatment, such as that with bisphosphonates, whether the patient is adhering to treatment, and whether the patient needs continuing treatment with bisphosphonates after 3 years. So the follow-up is very, very important to monitor the adverse effects, to monitor the adherence, and whether the treatment is needed after 3 to 5 years. So adults who have a fragility fracture or use systemic glucocorticoids or have a history of falls should have an assessment of their fracture risk. So who have had a fragility fracture, who use systemic glucocorticoids or who have a history of falls should have assessment of their fracture risk. So once again, fragility fractures, they are fractures that result from mechanical forces that would not ordinarily result in fracture, known as low-level trauma. So it's equivalent to a fall from a standing height or less. So it most commonly occurs in the spine, hip, and wrist. So fragility fractures are more common in people who use systemic glucocorticoids. So currently using systemic glucocorticoids or who have been using systemic glucocorticoids for more than 3 months at a dose of prednisolone 5 mg per day or equivalent doses. So either currently using glucocorticoids or who've been using it for past 3 months at a daily dose of 5 mg prednisolone per day or equivalent, they are at more risk. History of falls. So history of falls includes 1 or more falls in the past 12 months, so which is characterized by an unintentional or unexpected loss of balance, resulting in coming to rest on the floor, the ground, or an object below knee level. So it's an unintentional or unexpected loss. So 1 or more falls in the last 12 months. So adults age 50, if they have a history of falls, should have a fracture risk assessment. So once again, it's about estimating the fracture risk. Either FRAX or Q fracture can be used. above the upper age limits defined by the tools, consider people to be at high risk. Measure bone mineral density to assess fracture risk in people age under 40 years. So BMD using the DEXA is used to assess fracture risk in people age under 40 years. So once again, the risk assessment tools are FRAX and Q fracture. These tools measure risk differently and can give different levels of risk in the same person. So that's important. They measure the risk differently and can give different levels of risk in the same person. So if you have an adult with high risk of fragility fracture, NICE advises offering drug treatment to reduce the fracture risk. So the rationale behind is that fragility fractures can cause substantial pain and severe disability, often leading to a reduced quality of life and sometimes to decrease life expectancy. So taking drug treatment to improve bone mineral density reduces the chance for future fractures and related problems. So women with a prior fragility fracture and men and women with a 10-year probability of a major osteoporotic fracture derived from FRAX should be considered for treatment, as shown in the following table. Men and women with a 10-year probability between the upper and lower assessment threshold should be referred for the BMD measurement, and their fracture probability should be reassessed. If the 10-year fracture probability is above the intervention threshold, after reassessment, treatment should be offered. So women with a prior fragility fracture and men and women with a 10-year probability of a major osteoporotic fracture, you treat them. But if they are between the upper and lower assessment threshold, DEXA should be done and fracture probability should be reassessed. If the 10-year fracture probability is above the intervention threshold, after reassessment, treatment should be offered. So these are the lower and upper thresholds and intervention threshold for major osteoporotic fracture based on the FRAX. So the BMI is set to 25 here. So for 40, the intervention threshold is 5.9. And for 45, it goes to 6. To 50, it goes to 7.2. And as you see, as the age increases, the threshold also, the intervention threshold also increases. So in relatively younger persons, the intervention threshold is lesser. What are the medications which we use in osteoporosis? So basically the bisphosphonates, which includes alendronate, ibadronate, risedronate, and zoledronic acid, and non-bisphosphonates like raloxifene, denosumab, teriparatide, calcitriol, and HRT. Raloxifene has been withdrawn, so raloxifene is no longer used in the UK. So oral and intravenous bisphosphonates are recommended. So who are eligible for risk assessment, who have been assessed as being at higher risk of osteoporotic fragility fractures, and if the treatment is appropriate. So when you decide to treat, you take into account their risk for fracture, their risk for risk of adverse effects from the bisphosphonates, and the clinical circumstances and their preferences. So the meta-analysis confirms that bisphosphonates are more effective at reducing the risk of fracture than a placebo, because new analysis show that they are cost effective for people. That's why we recommend, NICE recommends bisphosphonates. So adverse effects and adherence to treatment. Adults prescribed these bisphosphonates are asked about adverse effects. and adherence at each review. Why? Because sometimes people stop taking them because of the adverse effects. So ask them to talk about their medications and their problems. And adherence has to be checked. Checking how well a person is managing their treatment at each medication review means that any problems can be discussed with their treatment, adjusted if needed, which will improve adherence and quality of life. So long-term follow-up. Adults having long-term bisphosphonate therapy should always have a review whether it's needed. The optimal duration of bisphosphonate therapy is unclear. That's rational behind this. And also there are possible adverse effects of long-term treatment. It also gives an opportunity to consider whether the continuing treatment is best option or if treatment should be changed or stopped. So adults who have been taking zoledronic acid for 3 years, or alendronate, ibudronate, or risedronate for 5 years. So zoledronic acid for 3 years and there are others for 5 years should have a review whether they need continuing treatment or not. So continue treatment if they are above 75 years, if there are previous hip or vertebral fractures, if there are one or more low trauma fractures during the treatment, and also if they are having any oral glucocorticoids of 7.5 milligram or more of prednisolone per day or equivalent. So prednisolone 7.5 milligram per day or equivalent if they're having it every day. So age over 75, hip or vertebral fractures or one or more trauma fractures, low trauma fractures during treatment, and prednisolone or equivalent, prednisolone 7.5 milligram day or equivalent if they are taking it. So they need to continue. For people without risk factors, you arrange DEXA and continue treatment if T-score is less than 2.5. And then you reassess the fracture risk and BMD every 3 to 5 years. You can stop the treatment if the T-score is more than minus 2.5 and reassessing their fracture risk and BMD after 2 years. So you can consider treatment if T-score is less than 2.5 and reassess risk and BMD every 3 to 5 years. But you can consider stopping treatment if the T-score is more than 2.5, the T-score is improved, and reassessing their fracture risk and BMD after every 2 years. So if you're continuing, you reassess in every 3 to 5 years. If you're stopping, you assess the BMD every 2 years. What about Denosumab? So it is recommended as a treatment option for primary prevention of osteoporotic fragility fractures. So it's used for the primary prevention only in postmenopausal women at increased risk of fractures or who are unable to comply with special instructions for administering alendronate, or who have an intolerance, or who have a contraindication, or who have a combination of T-score, age, and number of independent clinical risk factors. So only in postmenopausal women at increased risk of fractures who are unable to comply, or those who are unable to comply with special instructions, who have an intolerance or a contraindication, of T-score, age, and number of independent clinical fractures, risk factors. So the persons should be in women if they are postmenopausal, and in other persons who have this, if they are intolerant, if they cannot adhere with the treatment, if they cannot undergo the instructions, unable to comply with the instructions, or if they have contraindicated, or if they are a combination of independent combination of T-score, age, and number of independent clinical risk factors. So what are the number of independent what are the independent clinical risk factors? So I remember it by hair. So it's a parental history of risk fracture, alcohol intake of 4 or more than 4 units per day, and rheumatoid arthritis. So hip fracture, alcohol more than 4 units per day, or 4 or more than more, and rheumatoid arthritis. So based on these, and with the age, and with the T-score, you can see that treatment with Denosumab is indicated. So if you are 65 to 69, if there are no clinical risk factors, you don't need to, you can, it's not recommended. But if you are above 70 to 74, and if the T-score is minus 4.5, it is recommended. And in 75 plus, if the T-score is minus 4, it is recommended, or below. So in 65 to 69, if there is one risk factor, the T-score should be minus 4.5 for Denosumab, and with 2 risk factors, the T-score could be minus 4.0. In 70 to 74, if there is only one risk factor, the T-score is minus 4.0, for which Denosumab can be started. And in 70 to 74, with 2 risk factors, the T-score becomes minus 3.5. And again 75 plus, if there is only one risk factor, at a T-score of minus 4.0, you can start it. And if there are 2 risk factors, at a T-score of minus 3.0. I know this is complicated table. I mean, these are usually, it's very hard to memorize, but at times there are questions asked from these, based on these. So at least if you can study this table for the exam, you might be useful. Now, what about raloxifene? It is not recommended as treatment for option for the primary prevention of osteoporotic fractures in postmenopausal women. It is recommended as an alternative option for secondary prevention of osteoporotic fragility fractures in postmenopausal women. So secondary prevention means already people who had a fragility fracture. So raloxifene is recommended as an alternative for the secondary prevention. And who are unable to comply with the administration of bisphosphonates, or who have a contraindication or are intolerant to bisphosphonates, and then you who have a combination of T-score, age, and number of independent clinical risk factors. So again, for raloxifene, this is a table which recommends in which age group and with what T-score and with what independent clinical risk factors, the number of clinical risk factors, when to start the treatment. Again, the independent clinical risk factors are hair, so history of hip fracture, parental history of hip fracture, alcohol intake of 4 or more units per day, and rheumatoid arthritis. So what is intolerance to alendronate? So it is persistent upper GI disturbance that is sufficiently severe to warrant discontinuation of treatment, even if the instructions are followed. Teriparatide. Similarly, teriparatide is used for the secondary prevention, so it's used as an alternative for the secondary prevention in post-menopausal women, again, who are unable to take, or who have a contraindication, or who are intolerant, or who do not have a satisfactory response to bisphosphonates and who are 65 years old or older and have a T-score of 4 who has T-score of 4 or below, or who have a T-score of minus 3.5 or below plus 2 fractures, who are aged between 55 and 64 and who have a T-score of below or equal to minus 4 and more than 2 risk factors. So if the patient is 65, if they have a T-score of minus 4, you can consider that. But if a patient is having if the patient is 65 and the T-score is minus 3.5, you need to have more than 2 fractures for that patient. But if she is between 55 to 64, the T-score, if the T-score is less than or equal to minus 4, and more than 2 risk fractures, for 65 years, either an T-score of minus 4.0 or a T-score of minus 3.5 plus more than 2 fractures. For age 55 to 64, T-score of less than or equal to minus 4 plus 2 fractures plus more than 2 fractures. The recommendation for strontium has been withdrawn because strontium is no longer marketed in the UK. Thank you.